I'm going to wrap up our hematology presentations. When I'm done, we'll pull up an extra chair up here and have Q&A with all three of our speakers. I'm not only a member of CAGLA, but for this presentation, I'm speaking as a physician in the section of hematology at Ochsner, where I'm the section chair and the director of cell therapy. And I'll say the hardest thing about making this slide was making sure I didn't put too many S's in the word successes. There are so many. Make sure that was spelled correctly. But my talk is going to be on CAR T therapy. It's not as much of a scientific talk, but more of an advocacy talk about successes and barriers that we have as we're utilizing this treatment and trying to get it to more patients. As in my disclosures, I do participate in speaker bureaus and advisory boards for several entities. Our agenda today is very simple. This is my own way I spell CAR T. I think if it's in all caps, I'm yelling at you. So that's why it's phrased that way. But I want to discuss how is CAR T great, because it is. How is CAR T not so great, because sometimes it's not. And then to quote Matt Damon from The Martian, let's work the problem. Okay, so the beginning. I'm going to start off with a timeline, we'll kind of level set how we got here. And it's a little bit of a discussion of CAR T where it falls in a category of adoptive T cell therapy. Actually, one of the first people I spoke to this morning, we actually ended up discussing TILs. TIL, that's tumor infiltrating lymphocytes, and that's kind of where it starts. In 1988, first patients with melanoma were treated with this type of adoptive T cell therapy. It's removing T cells from the microenvironment of a tumor, expanding them in a laboratory, reinfusing them for enhanced anti-cancer activity. So it's kind of a proof of concept for adoptive T cell therapy. And then it's followed in 1993 by the first published description of CAR T. This looked great in vitro data, was disappointing in clinical trial data, but as the thing is, you keep change the construct and keep moving along, and it led to Helen Finney's second generation CAR T, described in 1998, that was adding the C28 co-stimulatory domain. It helped with cell proliferation, cytokine release, survival, and anti-cancer activity. And we saw another second-generation CAR T that came out in 2004, used a 4-1BB co-stimulatory construct that had a little more prolonged proliferation of the CAR, but we saw enhanced activity through memory T cells with this CAR T construct. The third generation arrives in 2010. It uses a dual co-stimulatory domain, and in the fourth generation in 2012, it uses nuclear activating factor-inducible cytokines to enhance activity. So that was all a mouthful. But by designing all these CAR Ts over time, what we saw was the clinical trials. You might know what the first clinical trial in CAR T was? It wasn't cancer. It was by Carl June, 1997. It was actually in HIV patients. Yeah. And then what we saw was the first actually cancer clinical trial with CAR T therapy was in 2010 in patients with leukemia. And we saw our success rise of therapy and the FDA approvals between 2017 and 2023. And then now what's exciting, one, we're using CAR T, it's becoming more accessible. We're seeing the research and technology move into solid tumors, which is making our oncology friends very excited. And then our rheumatologists are thrilled because now we're seeing clinical trials in non-malignant disease and systemic lupus. We're seeing trials in investigation and autoimmune disease that can be targetable. Or at least CAR T suppresses B cells, causes B cell aplasia. That's ideal for someone who has a autoimmune disease moderated by B cells. So success, I'm done. I just talked about all the success. No, there's more to talk about. So the idea is we're doing all these things, but are we helping patients? And I think the second question is more important, are patients satisfied? Are they living, but are they living well? What is their quality of life? Maybe a more important question. So we're going to check the boxes of success. So role in treatment. I think this is a success because one thing that's very frustrating is a new great therapy comes out and it's only approved for one rare thing. That's a success in a way, but it's very frustrating. So one of the successes is the diversity of disease we actually can treat CAR T with. Right now it is approved for BALL, for certain types of B non-Hodgkin's lymphoma and in multiple myeloma, sometimes in first relapse, I should say, or in later relapse in multiple myeloma as fourth or fifth line therapy. You can see by our circles, there's a lot of other areas we would love for CAR T to make it out to, but I think availability in more than one disease is success. So we're gonna check that box. Patient journey. So you may be able to see this. I was a little afraid by the size of the screen, so I was like, okay, now you need like x-ray glasses. But mainly CAR-T is described on the far right in the green boxes. I think the way CAR-T is changing the cancer journey, especially in relapse refractory disease for patients, is also a success. What I mean by that is this is a chart comparing what a patient has to go through and what they're at risk for, comparing autologous stem cell transplant, allogeneic transplant, and CAR-T. If we take, for example, patients with diffuse large B-cell lymphoma, prior to the CAR-T era in 2022, what the patient journey was, if you had relapse refractory disease, you had to get immunochemotherapy. You had to respond to that. You had about 30 to 40% chance that was going to happen. Then you had to go to transplant. Then you needed to have durable remission from transplant. 50 to 60% of patients relapse after autologous transplant. It's not a great patient journey for relapse refractory disease. The difference for CAR-T is you didn't have to make that milestone of disease response to get to your curative cell therapy. It takes patients to cell therapy that can be curative with active disease. That kind of completely changed the dynamic. So it takes patients to a curative therapy that may not have had an option otherwise. So I'm like, success, or we're going to check that box. In that regard, these patients who otherwise had prognoses that were probably less than 1 to 2 years, and I mean that in patients with relapsed ALL, 4th or 5th line multiple myeloma, or with original approvals for CAR-T in lymphoma or later line, now in 2nd line, their outcomes were pretty as bad as I just described. We're seeing a difference. This is a graph of the initial clinical trial data for our 6 approved agents and where they're approved. We see overall response rates that are way better than 20, 30%. They are at or above 50% in overall response rates, and complete remissions are also at near or over 50%. And if we read the trial data, this is often MRD negative complete remissions. These are original reports of the duration of response. Of course, we originally reported it as short, but now we have later line reports of long-term outcome data that's coming out at our ASH, ASCO, and ASTCT meetings that can exceed 2 years for much of these agents. So we're looking at a prognosis that was 1 to 2 years, now exceeding 2 years with cellular therapy, with patients going to a treatment with active disease. So we're going to check that box. All right. So the bigger question that I learned through some work with NMDP, where we did some one-on-one sessions a few years ago of patients and caregivers that had gone through transplant, is learning that they have a completely different perspective of what is a success. It's usually living well, not necessarily being cured of your disease. Sometimes if you can maintain cancer but still live well, that's an achievement also. So asking the question, are patients happy? It's kind of how my word for quality of life. I'm going to show you two studies. This is actually transplant data. This is a study that came out from the Cleveland Clinic for patients that were age, okay, Dr. Alsfeld mentioned about not being offended by the definition of older age. It gets worse in this study, so I'll just warn you now. But it was a study of patients having an allogeneic stem cell transplant with myeloablative conditioning chemotherapy at the Cleveland Clinic between 2003 and 2017. They have 3 age groups here. I'll tell you what they are. AYA is abbreviation for adolescents and young adults. AYA1 is 15 to 29. AYA2 is 30 to 39. Older adult is 40 to 60. Okay, so the reason they actually did this study is, sorry if I take a drink. The reason they did this study was actually we're concerned that the youngest patient population was report just awful quality of life undergoing through transplant. They used the FACT-BMT survey. It's a 50-question survey. It has some general questions, but an additional 23 questions specific to transplant. All the FACT surveys look at 4 domains of well-being. It's physical well-being, functional, social, and emotional. And they thought the youngest patient population was going to be devastating in these reports because at 15 to 29, you're graduating high school, you're graduating college, you're getting your first job, you're getting in your first long-term relationship, you're having children. So they thought they're going to have to address quality of life issues in young adults, but actually what they proved is everyone's very similar. There's a dip in the first 100 days of transplant. That's when you're in the hospital and in your most acute care, and you see it rise over time. So one, I'm going to point out, look at the time frame that's being described for transplant. Baseline is a month before transplant. Day 100 is the most acute period. Then they had 180 and 1-year follow-ups with these patients. If you look further in the paper, the greatest decline was actually in social well-being, mainly for the older adults. When we're younger, we make friends easier. It gets hard to make friends when you're older. We'll put that out there in the world. But second, your social circles become more diverse. And so our patients undergoing a transplant are very socially isolated other than their most intimate family and friends. They lose their social circle at church. They lose their social circle at work. They lose their social circle at large and become isolated. So I mentioned it does rise back to or above baseline by the end of this, but this is a really prolonged period of dealing with a lot of different domains of quality of life. Fortunately, we have a little bit of a comparator. This is from Mass General Hospital, and it looked at CAR T patients. And again, they have a whole different definition of older adult. They looked at patients 23 to 90, so we're back in the game at 40 years old. It was 100 patients undergoing CAR T therapy. Majority were for lymphoma, about 30 patients for multiple myeloma, and a single adult hung in there for BALL. And they did something very similar. They administered the general fact survey, so this was a 27 questionnaire, that's why the scale is a little bit smaller. But you look at the time frame. So, and that actually is consistent. When we can administer CAR T therapy, the duration of their kind of intimate care at the treating center is much shorter. And it reflects what we do in CAR T. That first week, they're in the hospital for about 9 to 14 days. That's sort of the greatest period of isolation. You see that's exactly similar to the 100 days of transplant when they reported their worst quality of life, but it very rapidly then rebounds even higher to their baseline reported quality of life. So you may not have thought of that way, but that's a success of CAR T therapy, where patients for domains of well-being have a similar response that it does to transplant, but they can actually recover much quicker in their quality of life outcomes. Another box to check. Well, the clinical trial world is a special world. Sometimes it doesn't quite reflect reality. So what is important is real-world experiences. This is data from the CMS, the Center for Medicare and Medicaid Services, looking at patients receiving with reporting that they're receiving CAR T therapy between December 2018 and the end of 2022. Is this for diffuse large B-cell lymphoma? And it was asking, we're talking about older adults in AML, or older adults, and here it's 65 or older, are they receiving CAR T therapy? What is the utility in the community, and are they having successful outcomes? And it was concerned that our older patients would have worse event-free survival or overall survival. How they gathered this data is interesting, is that it's patients who had at least 2 codes for an outpatient visit with relapsed refractory diffuse large B-cell, 1 inpatient code, it was either or, and sometime after that, a code for a procedure for CAR T. So that's how they estimated patients were getting CAR T therapy. And we see about, right around 15 to 20% of our older adults are receiving CAR T, so that's a win. And we see across the age ranges, there is very comparable event-free survival and overall survival. So this is evidence we can take into our communities to please refer patients with relapsed refractory diffuse large B-cell for therapy. So, check. All right, so successes in progress, I should say, is where CAR T therapy is going. So this is a snapshot of clinicaltrials.gov of what active trials are enrolling for cellular or CAR T therapy. And this moment in time, it was early in 2023. At that time, 448 clinical trials enrolling for CAR T therapy. But I think what is important is now solid tumors are sneaking into the list. We see CAR T therapy trials for hepatocellular carcinoma and solid tumors. The list of probably, if we took a snapshot today, is probably even greater for solid tumors. And then the success in progress is how we may move CAR T therapy out of the world of oncology. And how this came about is a patient having CAR T therapy for diffuse large B-cell lymphoma also happened to have lupus. When they got their CD19 CAR, it actually put both in remission. So yeah, see, happenstance. Happy accident by Bob Ross, right? So, so now what we see is clinical trial utility researching CD19 CAR T, really with the intent to use that B-cell aplasia that you can create with CAR T therapy as a treatment for autoimmune disease. Lupus is an ideal candidate because it has both clinical and laboratory outcomes you can measure for subjective and objective responses. So More to come in the world of autoimmune disease. Okay, barriers. Oh, that's the one that's always elephant in the room. I will get to that. But there's others. Let's talk about some others, because it's not only about cost, it's sometimes about getting someone where they need to be for therapy. So hematology, what I referenced here, if you don't know, if you're a member of ASH, you have free access to it. If you attended the annual meeting, you do also. Hematology is their annual education publication that coincides with the annual meeting. I mention it because they have great little snippets about cell therapy in their publication this past year, and had this great, actually, there were short read articles about barriers and CAR T, so that's where I stole the graph from. So it doesn't just deal with cost. We'll back up and we'll use the first box on the top left, is knowledge and familiarity. And this is an issue. So there's the fact that we know cellular CAR T therapy is available, but there's still education. We can get out to the community of who to refer. Like now it's a confusion of where in the line of lymphoma do we need to refer someone. It used to be late line, now it's early line. This may happen in myeloma soon because we know it's late line, but hopefully it will soon be early line in multiple myeloma. Which B-cell non-Hodgkin lymphomas actually qualify? My very first referral for CAR T was a Hodgkin's lymphoma patient. So that's that disparate need for education in the community of who qualifies, and this doesn't deal with age, it doesn't deal with race, it's by their disease and where they are in their relapse or their refractory disease. And then realizing we'll be sending patients out to communities to manage what can happen to be late-term toxicities. So we'll provide that education to take any fear away from referring in community centers about co-managing patients that they happen to have a late toxicity. There is the cost and insurance coverage issue. Again, we're going to get to that. But on top of what we have to cover for the cost of CAR T and work with our payers, a reminder that our patients have all kinds of costs that are in the background that sometimes we don't think of. There was a discussion of patients who don't live in the vicinity of a metro area. That means if they're going to try to get the therapy, they have to pay travel costs. And that usually means them and a caregiver has to take off of work, and they may have to find lodging and be able to stay long enough for the referral. They got to stay in the vicinity for the CAR T therapy itself. They got to travel back and forth for their follow-up visits if the treating center isn't offering virtual visits. So it's all the other costs that piles up on patients in addition to what we're working out with insurance. There is product administration issues, which I'm going to say are yay to pharmaceuticals is getting better. But we do deal with about a 17 to 60 day, at its worst 60 day, from time from leukapheresis to time to return a product to treat a patient. We have had, as a new CAR T therapy site, the experience of patients progressing in that time period despite bridging therapy, even a death while waiting for CAR T product return. So lots of work. It is getting better, but still work we can improve in there. And in the site of care, we're going to show some maps. But again, there is data that came out, and it was describing that patients are like basically at the academic center, they're diagnosed, their cancer journey is there the entire time. If they are referred for CAR T therapy, they're 90% likely or greater that they will get CAR T from referral and be treated. If they live more than 2 hours from a treating center, for time from referral to CAR T, the likelihood of success is 47%. So it drops by more than 50%. So sites of care is a significant issue. So mentioned, I may have already described, knowledge and familiarity. Again, it's getting patients, kind of looking at the clinical trial and real world data, making sure patients who are eligible actually do get a referral. And then that there'll be education to our colleagues about late-term toxicity to take any fear away, because we still even see a little bit of fear of returning a transplant patient to a community, taking away fear of returning CAR T patients, because we will have to co-manage them with our communities about the biphasic cytopenias. They think, we thought you cured them. It's like, well, this happens too. Late occurrence of HLH, which can be scary. Managing B-cell aplasia with IVIG, making sure patients are getting the vaccines on schedule. So we need to work closely with our cancer care communities, make sure we're all comfortable in patient care so that's not a barrier to CAR T therapy. We've seen some great maps today, especially in Dr. Cole's talk. I'm going to show you some more. This kind of dovetails into what he was speaking about in myeloma, about access to myeloma clinical trials. This is access to CAR T and BITE trials. Really great publication from JAMA, comes from the University of Arkansas that looked at this. That interestingly, the South, primarily Texas and Florida, have the majority of CAR T clinical trials. Interestingly, the majority of our Black population lives in the South. Interestingly, only 35% of our Black population actually had access to clinical trials because of where they live. So the idea of actually getting trials where we can, closer to where patients live, we have that data. If they live more than 2 hours from where they can get care, they're not likely to get care there. To try to branch out clinical trial access to our minorities. In regards, if you look at the clinical trials for CAR T, about 2 to 4% of patients enrolled were African Americans. In BITE trials, it was a little bit better, it was about 18% of patients enrolled were African Americans. So this is access to care and clinical trial enrollment, as we discussed at our first presentation, is a barrier to care. Okay, I'm not necessarily saying BITE therapy is a barrier to CAR T therapy. No one get offended. But there's some issues with the ease of access that may be preventing patients from getting curative therapy. And there's an issue, the barrier for us as providers, is we don't know how to sequence these things, and we're still trying to figure that out. So it's hard to get to a CAR T treatment site. There's 307 FACT-accredited transplant programs across the nation. Not all of them are, but those are also the sites that tend to be CAR T treatments. But similar to the map Dr. Cole saw, they're not evenly spread out. They're like every state gets 3. They're in specific areas of the country, so there's actually deserts of transplant and CAR T treatment centers. Therefore, what is accessible in the cancer clinics is BITE therapy, because that can be in anybody's office, and it doesn't have to be a FACT-accredited transplant program. So there is actually an ease of access to BITE therapy, and it may delay patient referral to CAR T therapy. We don't fully understand what it does to responses. So it's kind of a wealth of what we have, and then figuring out how to use it. So I'm not going to say, it doesn't quite check it's like half a check for a box as a barrier. And then coming off of Dr. Alsfeld's talk of treatments we have available for AML, this was a hot topic at ASTCT last week. There was great monumental efforts undertaken to try to get CAR T therapy into AML. It is the most common leukemia in adults. It is, myeloma is not, B-cell lymphoma is not, ALL in no way is the most common leukemia in adults. It is AML. And it's the issue when we haven't seen successful CAR T therapy in AML just yet. Lots of issues. Most of the issues are on the right half of the circle, is that there's attempts at, and we'll discuss how somehow it's getting better, attempts at using allogeneic CAR T, but then you have the issue of graft versus host disease, issue of finding the right antigen that doesn't attack like your lungs, your intestines, and your testes. That would not be great. Trying to develop technology that allows the CAR T to persist, and technology that when you do design a CAR T for AML, it doesn't create basically total bone marrow aplasia. Okay, that's not great either. So trying to figure this out is a barrier to getting CAR T therapy to a significant patient population in need. And then we always deal with the other things. So we talked about a little bit of the wait to get CAR T to patients, that wait list issue, and that's not always a manufacturing. I'm not going to put that all in pharma. That is not always a manufacturing issue. Sometimes it's a treatment site issue. Each treatment site has only so much capacity to take on so many transplant and cell therapy patients at a time. So it's a combination of those factors. And then we've had the joy of dealing with the random and spontaneous drug shortages. This has been this is a fun roller coaster to ride. That in the thick of the pandemic, when everybody realized tocilizumab was a great anti-inflammatory and gave it to everybody with COVID, and then us as cellular therapists were like, oh my God, you used up all of our tocilizumab. So we dealt with a tocilizumab shortage in 2022 in the thick of the COVID pandemic. Please don't ever do that again. And then in this past year, if you're like us at Ochsner, we're a statewide healthcare system, but we had to deal with a fludarabine shortage that we're just kind of coming out of. If you're familiar with CAR T, fludarabine, Cytoxan is the lymphodepleting regimen for CAR T. So it's not fun to have a fludarabine shortage when you're starting a CAR T program. So this has been another barrier to cell therapy, is the random and spontaneous drug shortages, which is, I think one of the current ones is methotrexate, and we're a primary site for primary CNS lymphoma. So this is fun to deal with. Okay, elephant in the room. It's expensive. So there is both institutional and patient financial toxicity that we deal with CAR T therapy. This is a report of the cost of all of our approved agents as of about basically a year ago, March of 2023. Everything at or over $500,000. The uncertainty of what it's going to cost is a barrier to care. If there are CAR T providers in the room and you're like us, you have to negotiate a single case agreement for every single patient. That's not fun to do when the price keeps changing. That means you're renegotiating from scratch, essentially, every time. And what we see is that the cost just keeps going up. So somebody fix that. Okay. I'll give some suggestions how we can lower the cost of CAR T therapy, but at least stop if you can, but not like next year. So now this slide is outdated because it's a report from 2021 of, if you look at total cost, so that $500,000 just, hey, I need the product. Then you realize we got to do all these things to the patient, and that cost $600,000. So back in 2021, the average cost to actually provide total care is $1 million. It's actually $1.5 to $2 million now per patient to provide CAR T therapy. So we just slow that roll. we appreciate it as a CAR T treatment center. All right, so work the problem. As Matt Damon says, how we get off the planet of Mars successfully is we brainstorm and we think of unique ways to solve the problem. Okay, so first we'll jump into areas of need, because this is probably one of the easier ones to talk about is where research and technology is going to try to get CAR T therapy not necessarily to solid tumors and lupus, but actually to more patients with different types of blood cancers. So again, one of the hottest topics at the ASTCT, that's the Transplant and Cell Therapy meeting that was last week in San Antonio, is one of the issues with AML is finding the right antigen to target. So you look on the far right, there's a little plus sign all the way down the road. It means everything you see here is an antigen on the surface of leukemic stem cell. But then look in the middle and see what else it's on. And there's all kind of normal tissue and healthy tissue listed there. Maybe your lungs, and maybe your intestines, and maybe your CNS. Not really things we want to attack with your immune system. So finding the right antigen has been one of the major issues. And I'm going to have a better slide than this one, but using research and technology to find ways to overcome that and the issues of getting the CAR T where it needs to go. This is a better slide. All right. So what do we need to do? We could go all day on the science of trying to create CAR T for AML. So I'm just going to mention some of the things that are being attempted. And the top left is dealing with the tumor microenvironment. Like many cancer cells, AML is great at creating a force field around itself of other cells to protect it. So trying to use other technology like PD-L1 inhibitors to be able to get better access of CAR T therapy to its cell of target. And top right, limiting on-target off-tumor effect. That's this antigen issue. They're looking at antigens that aren't really on healthy tissue. Right now, CD70 is one of the ones on interest that's on a leukemic stem cell, T cells and B cells, but not on actual tissue of the body. So trying to pick the right target. Trying to create knockout. So if you can't necessarily pick a target that's not on anything else, knock out the target and all the healthy tissue so it can only attack the malignant tissue. That is a thought. Trying to modify the CAR itself. So NK cells were of interest, especially, again, at the Tandem meeting, using CAR NK cell. NK cells kind of arise from lymphocytes. It's also kind of its own entity. They're involved in our innate immune system, but using them does not cause graft versus host disease, CRS, or ICANS. So like, what? So if you put that on the right target, we may solve all our problems. And then also trying to manipulate manufacturing. Again, mentioned allogeneic CAR T. That is using healthy donors, not the patient. Right now we take the cells from the patient themselves, but using healthy donors, creating your CAR T of interest, freezing it, putting on a shelf, and creating an off-the-shelf demand product. And by doing that, they use CRISPR technology to knock out the major histocompatibility complex, so you actually can prevent graft versus host disease. And some great early first-in-human trial outcomes in AML we're seeing from this technology. I mentioned that one specifically in that timing, so dovetailing the next slide is technology like that may help solve some of our financial toxicity problems. Right now, it's creating the as-needed product from the patient and then all the manufacturing and delay and difficulty issues that go with that. If you can actually create a on-demand, off-the-shelf supply from healthy donors, takes out a lot of the manufacturing risk and delay, and that may be one of the ways to actually reduce cost of therapy. All right. Another barrier that we can potentially overcome as communities is working through social determinants of health to try to help the patient that lives 2 hours away or who lives in poverty actually get to a treatment center, just get the referral, get to a treatment center, and hopefully have a successful patient journey through care. I would like to actually give accolades. The more and more I talk to our companies that make CAR T therapy, their patient assistance programs are dramatically improving and providing quite broad assistance with travel and lodging to try to get patients from their home to a treatment center and back with minimal out-of-pocket cost to patients. It's a work in progress, but look, we can almost put that in a success box also. All right. 2 sobering slides. I'm going to depress you, and I'm going to bring you back up. Okay? All right. So Medicaid is an issue, as we talked a little bit about cost. 74 million adults are covered by Medicaid as of information beginning of 2024. It's almost 20% of our nation's population. Medicaid in no way, shape, or form covers CAR T. Up until recently, it didn't even acknowledge CAR T as a therapy in the state of Louisiana. So this is a sobering report it was an abstract at ASCO last year from our Ochsner friends at Ochsner Freeport. They have a very large Medicaid patient population there, and they looked at their patients with relapsed refractory diffuse large B-cell lymphoma. Patients had Medicaid compared to patients who had other insurance, and this was patients between 2018 and 2022. And 33% of those patients were Medicaid, and they were eligible for CAR T. They couldn't even get a referral. No one would even look at their case, or they couldn't afford the cost because if they have Medicaid, they were underserved financial population, could even travel to the referral. And by comparing the patients who never got the referral and they couldn't make it there or were even accepted by insurance, those that did, 60% mortality in our Medicaid population, 0% mortality in our patients who got to CAR T. So this is a mountain of a barrier we have got to overcome in some way. I don't want to put it bluntly, but it's like we're letting our fellow Americans die. So I'm going to press you and I'm going to bring you back up. I'm going to press you a little bit more. This is not the bring you back up slide. So this is actually from the American Society of Transplant and Cell Therapy, and also looks at Medicaid and the state of the nation of Medicaid coverage for transplant and CAR T. And I have some really sad facts to announce. So, number 1, not a single state in our nation covers transplant by Medicaid by ASTCT or NMDP guidelines. No one does. 10 states do not acknowledge allogeneic stem cell transplant for MDS or sickle cell disease. They say it's not a therapy. More, 7, I'm not going to name and shame the states, but 7 states by Medicaid have discriminatory restrictions and don't cover allogeneic stem cell transplant if you have a physical disability, if you have a mental health diagnosis, or you're defined as obese. All right? It's not going to get better yet. When we look at CAR T therapy, Medicaid is awful right now for CAR T. I'm just going to lay it out. 14 states say they cover it, but they don't. They actually say they cover it, but they deny it if you've had a prior allo transplant, if you have HIV, hepatitis, if you are obese, or if you have cytopenias at the time of your referral. Okay, so a lot of work. So this is probably one of the greatest areas of work we can do in advocacy. So to take Louisiana out of those lists, bring you back up slide is actually CAGLA, since we're at a CAGLA conference, the No Cancer Conference this year, actually lobbied all year at the state legislature on this issue of Medicaid, not even acknowledging CAR T in the state of Louisiana, actually went above and beyond that. I'd like to announce in July, this is the picture of the signing, Governor Bell Edwards actually signed in legislation that Louisiana Medicaid program has to cover CAR T for eligible patients as defined by guidelines. So, That was effective August 1st, 2023. You can't clap yet because there's access and there's access. So the legislation is now there. The money is not. So now it's an issue of working on the funding of Medicaid coverage for CAR-T, but we may be the first state in the nation to actually acknowledge it by guidelines of eligible patients. So lots of work to do. So my summary is kind of my agenda. A lot of successes, a lot of really phenomenal successes in CAR-T therapy. There are barriers that exist, but these hopefully past few slides show if we acknowledge the problem, we can actually start to work through them. All right, thank you. All right, so I'm going to bring an extra chair up here and bring my co-speakers up, and we'll be answering some questions.
I love that question. Thank you. Yeah, so the question is, how do you deal with patients from the time of diagnosis while we're waiting for the molecular analysis? And I think it's a really important question. What I often try to highlight to a lot of our community partners is that we do have time. There are some data, some studies that look at time to treatment, and I forget exactly off the top of my head, but essentially the time from diagnosis to treatment, again, highlighting the shift in focus. It used to be you have diagnosis of AML, you come in, or let's say take a little step further, you come in with a cold, you think you're in the ER for a cold, by the way, you have acute leukemia, by the way, here's your hospital bed, people start thinking they're dying tomorrow, and then they spend a month and a half in the hospital receiving treatment and really beating people up. To me, I was fortunate to train in the environment that was the case, and now as a practicing leukemia doctor, I see it has shifted, and I have seen significant improvements in the mental health of our patients and in the strength of our patients and courage. And so using that question, I really try to highlight that we do have time, and I work with Dr. Yang back there to try to quickly get these molecular profiles back quickly. But it still takes about a month, and so we still have a month, and in that time frame, what I always tell patients is as long as they're clinically stable, they don't have comorbidities that would potentially run the risk like renal failure or other issues, and they're clinically stable, we can watch them safely. I usually check labs twice a week, make sure they're on all the prophylactic antimicrobials, and while we can wait for that molecular profile. I don't look at leukemia as 7 and 3 or not. Nowadays, I think of all of these regimens, and the molecular profile really helps us tailor the therapy to the individual and their disease, and in that time frame with the right supportive care, so far, knock on wood, have not had any issues with patients, and we now have data that it's safe.
But if they come in hypoxic or whatever, you got to treat it.
In those situations, and it depends a little bit, we can get the FISH and karyotyping back fairly quickly, and so if we see complex karyotype, then we know we're probably shifting more towards a less intensive, or not less intensive, like azaven or something like that for those patients, because they're more likely to have a biallelic TP53 or some other mutations where 7 and 3 is probably not going to benefit them. If they're hypoxic or have other issues, we really try to tailor and help them get well. And rarely nowadays, even if they're very sick, do we need to start therapy like induction therapy right away. Usually hydrea enough to cytoreduce to keep them safe is enough. That's a good question. Thank you.
I have a question. Can I?
Yeah.
Dr. Fenn, do you think that CAR-T will ever get out of the being associated with academic centers and being because you showed, I showed, I think we've all showed, these giant deserts of therapy. And do you think that a general oncologist I'm going to pick the state that had the fewest availability, which was New Mexico, where there was like nothing there that I saw. That general medical oncologist in New Mexico can give a CAR-T.
That's a great question. And I actually, at present, don't see a pathway out of the academic centers to the general oncologist for CAR-T therapy. I say that now, but when you think of things like off-the-shelf allogeneic CAR-T that may make it more accessible, there's a possibility in years to come. Because right now, get a little of the technical speak of CAR T therapy, the way we get there is very similar to how we get there for a transplant. I think that's one reason is it is in the academic transplant centers where you have to have your apheresis department essentially for cell collection, just like we collect stem cells, we're collecting lymphocytes. You have a stem cell lab that's able to process it and package it and handle it to and from where it's going. And then right now we have our cell therapists, they're often your transplanter, managing the infusion and the side effects that go with it. I think, one, if you think of some of these CAR T designs that are being researched that may possibly be able to dramatically reduce the incidence of CRS and ICANS, even some of the late effects, that is kind of overcomes a barrier to getting it to a journal oncologist. The accessibility, where you necessarily, if you have off-the-shelf allogeneic product where you're not needing all the departments that are in your transplant center, that may be a way to overcome a barrier to getting it into communities that are like those deserts of access to transplant or cell therapy. But the caveat, there's still a lot of very unique care that's needed for a CAR T patient, and it may change the dynamic of the relationship and how a cell therapist and a general oncologist may interact with each other. And I think the virtual health platforms now create a lot of possibilities that if CAR T ever does move into the communities, cell therapists may not need to be there physically, but can actually be assisting in a virtual way also. But figuring that out, I think, is something we got to think very creatively about to get access within a 2-hour distance of all patients. Thank you.
Thank you.
I have a question. So in regards to referring patients and the academic centers only being in certain states, how, if you want to go to more a telehealth option and reimbursement for those patients, and is that an option for them to virtually see you if they're not in that same state? Or
Is that me? Yeah. So great question. And at least at Ochsner, and I hope it's for a lot of institutions, the answer is yes. And I'm going to actually plug for both clinical trials, like we were speaking of clinical trial access for myeloma and for CAR T therapy, is that we were very willing, because you can receive information electronically, so you can get records and data about patients electronically. We are both willing, and we do, in our cell therapy department and our clinical trials department, we call it the first consult intake visit, do that virtually. I know in our transplant program, Dr. Alsfeld and I, if needed, we'll do as much as humanly possible virtually for a patient to prevent those cost barriers of traveling and lodging to get back and forth to visits until they have to be, well, we have to, you can only do so much when you only see someone's head. Like when they roll in a wheelchair, like, oh my God, I did not realize. But so you have to see them in human form at least a handful of times, but doing all the other excess things virtually, we attempt to do, again, to overcome some of those social determinants of health and barriers to access.
I got bad news.
Oh no.
So, it was during the pandemic and after the pandemic when the telehealth coverage for the emergency telehealth coverage was in place. It was, great for me because I had patients all over, really I had patients all over the world that I saw for second opinions. And I was able to direct, including a lot of areas that were, the deserts we've talked about. Places in Hawaii, which, don't have any transplant center in that state. And so I did consults through telehealth in Hawaii, places throughout the southeast, and the west, and in the northeast, again, that were far away. And then that was May of this year, when the emergency telehealth insurance coverage dropped, all those patients disappeared because it wasn't reimbursed and they were having to pay. We called a patient yesterday and she was going to have to pay $300 and some for me to do a telehealth follow-up with her And so now all the telehealths that I do, which I'm happy to do, but they're within the state of Michigan, and I really can't go outside that now. And so I know, at least in Michigan, we're trying to bring back, if we can get some of that coverage through, to be able to do telehealth in more remote areas through the United States, because I thought that was a huge benefit. Because at least in, we use a 4-drug induction regimen for myeloma as kind of the standard of care now. I found out in Hawaii they weren't doing that. So I sent my note and did everything, and then the doc was like, oh, yeah, I guess we could do that. And so just with one telehealth, and just one note that I sent, we were able to change the entire way that they were treating, newly diagnosed myeloma patients in Hawaii. And then just think if we could do more and more of that and have more of a mix of ideas and reach those places that don't. I mean, the slide that I show where academic centers had survival here, other centers had survival down there. If we had telehealth, we could probably bring those back together.